groupings, so a white grouping, a black grouping, Bangladeshi Pakistani grouping, Indian grouping, Chinese grouping, mixed and other. Now the headline finding is that the risk is significantly higher for some of those ethnic groupings compared to the white ethnic grouping. So we already know from previous work that we've released and published that things like your age, things like your gender, and things like where you live, your location, are key things in terms of people's likelihood thus far of dying with COVID-related issues. So what we've actually got is kind of your probability of dying with COVID is made up of two things. Firstly, your probability of actually being infected in the first place. And then secondly, your probability of dying once you have been infected. Now, those two things are influenced by your personal circumstances to a large degree. So the first thing we did is we looked adjusting for age and what the difference was in terms of risk of dying by these ethnic groups. And that brought out some quite stark differences. So just adjusting for age, we saw that the black ethnic grouping was just over 4 times more likely to die of COVID-related issues than the white group. The Bangladeshi and Pakistani grouping was about 3.5 times more likely, and the Indian grouping about 2.5 times more likely. But we know that
Nick, this is really, really interesting and important data, because we've been talking for a while now, interviewing various doctors and experts who have been examining this both in the UK and elsewhere in the world, the reported and suspected link between ethnic background and higher rates of infection with COVID-19 and death from COVID-19. So you're saying in your study, when you factor in other issues like age, socioeconomic status, etc., that people who are black are 4 times more likely to both be infected or die from COVID-19, from a Bangladeshi background 3 times more likely, and Indian 2 times more likely.
Halfway there. So those figures are just when we adjust for age. But we know other circumstances matter. So we want to try and introduce those other circumstances, which we can do because we have geographical location from the death certificate and the death registration. So we know, for example, that big cities like London, Birmingham, Manchester, etc. have been more affected. We know from figures that were released last Friday that whether you're in an urban or rural area matters. Your area's relative level of deprivation matters. So there's really a strong social gradient to mortality rates generally, and even more for COVID. We showed that on Friday. So we needed to adjust for all of those other factors as well. So geography is a key one, and then other socioeconomic factors we could get data from the census records that we linked the deaths to. So things like people's qualifications, people's kind of housing circumstances, what type of jobs or occupations they had, and their self-reported health.
So there's a lot of data here, Nick, but the broad headline, the important headline from all of this is that you have been able to show that some ethnic groups have a higher risk of COVID-19 related death compared with those of white ethnicity. That is the big story from all of this. Is that right?
Yes, but when we adjust for all those other things, then actually those rates that I told you earlier come down significantly. So a lot of the difference can be explained by these geographical and socioeconomic factors. And what we're left with, once we've adjusted for that using regression models, is that the black ethnic group is now about 90% or 1.9 times more likely to die from COVID-related issues. Bangladeshi and Pakistani males are about 80% more likely, females about 60% more likely, and Indian females are about 40% more likely, and males about 30% more likely, once we've adjusted for all those factors. Now, there are other factors we would like to introduce and develop the model further. So your risk of being infected, for example, may be affected by the type of occupation you work in, or indeed the type of occupation that members of your household work in. And it could be the case that some ethnic groups are more likely to be in public-facing occupations. Another thing we'd like to look at is people's underlying health issues. So it may be the case that certain ethnic groupings at certain ages are more likely to have perhaps heart disease or diabetes, obesity, asthma, etc., etc. And we'd like to be able to see if how much of that difference that we've now got left might be explained by some of these other factors. But our headline just under twice as likely for the black group, and then about 70% more likely for the Bangladeshi Pakistani group, and about 30% more likely for the Indian group compared to the white group.
Okay, a lot of data to take on board, some really interesting findings, which people, of course, can go to the ONS website and Twitter account to find out more about. That's Nick Stripe, the head of health analysis at the Office for National Statistics. Thank you very much. Well, let's get some reaction to all of that with Dr. Bharat Pankhania, who's an expert in communicable diseases at the University of Exeter. Very good to have you with us again. Does what Nick Stripe from the ONS has just been saying, does that back up what you have suspected, believed in relation to COVID-19 deaths and ethnic background?
Yes, and thank you for inviting me. This is really good work by the Office for National Statistics, and we are very grateful to them for doing this so quickly. Now that this great big red flag has been raised, that the ethnic minorities, Black, Asian, minority, ethnic people have got an added risk. We must do something about it immediately. I appreciate by the time you have cleaned up the data for location, geography and other things, the risk came down quite a bit. Nevertheless, we've identified that they are at added risk. We've got to do something about it. In other words,
can I come to what we do about it in just a second, Doctor? But can you firm up to any degree what Mr. Stripe was suggesting might be the reasons for this differential between people of white ethnicity and people from other ethnic backgrounds? Is it to do with a predisposition to have certain health conditions? Is it to do with type of employment? What do you think is the reason?
I think it is a combination of all of them, without a doubt. So there is geography, meaning if you live in a deprived place, you are less likely to be able to sit at home and do your work by Zoom. Whereas, you'd have to be a taxi driver, a bus driver, train driver, work in a crowded place, more chance of getting infected. And then on top of that, the Asians and others do carry an added risk, which is diabetes, blood pressure, heart disease. So all those things put together, we identify they are probably at a slightly extra risk.
So let's come back then to that very important point that you were just moving on to. What do you think should be done about this? What measures can be introduced to try to get rid of this differential so that people from these ethnic backgrounds have as much of a chance of actually fighting this disease as someone of white ethnicity?
So we've got to, now that we know, we can say, look, we need to reduce your face-to-face consultations. Where face-to-face consultations are absolutely necessary, we are going to give you enhanced